Hello, my name's Dr. David Hindmarsh and this is GP Templates. In this series of videos we're going to look at CPD and how that can be converted into quality improvement projects. In this video we're going to look at the recommendations based from Why Asthma Still Kills and see if we can alter the templates that we're already using into improving care for our asthmatic patients. So, Why Asthma Still Kills was a confidential inquiry that looked at recent asthma deaths and whether they could glean any circumstances that led up to those deaths. They found that they came up with certain recommendations that we're going to look into more specifically, but I would actually advise you to go away and read this article because it's very much well worth having a look at and looking at the background that led up to some of this. So let's have a look at some of the recommendations. So some of them I would hope that we would already do in a primary care. So for example, having a named clinical lead for all our asthmatic patients. They recommend that any patient should be referred to a specialist asthma service if they have multiple requirements for steroids, whether it be oral or injected over the past 12-month period, or if they're up to step 4 or 5 on the BTS stepwise ladder guidelines. Follow-up arrangements must be arranged after every emergency admission, and they recommend that a standard national asthma template is designed and created. And also they recommend that we have some form of electronic surveillance of prescribing in primary care. And finally they recommend a national audit of asthma. From a medical and professional care, they recommend that everyone has a personal asthma action plan and that they require at the very least an annual review with a trained professional. At that review, they must have a look at how their symptom control is and also must document what triggers or what exacerbates their particular asthma. Finally, you need to have a look at what other psychological or mental ill health issues may be arising at the same time. That again would contribute to their increased risk of mortality. From a prescribing and medicines use point of view, they're advising that if you're using more than 12 reliever inhalers in a 12-month period, then actually that could recommend some quite dangerous habits, and so they should be invited in for a review before step up in their treatment. There must be an assessment of inhaler technique as well, and also those who are non-adherent to inhaled corticosteroids should be monitored very, very closely. And also when stepping up to a long-acting beta-2 agonist, that this must be combined with an inhaled corticosteroids to promote use of both. Okay, so we've got quite a few recommendations there, and obviously the article goes into a lot more detail of where they've come about. So let's have a look what information we've got already and what we can use already. So speaking to our respiratory nurses, we currently use the QIP based asthma template, which goes through, it's got the RCGP 3 questions, tick for asthma, annual review that it's been done, and also as well as hitting smoking and some other bits and pieces. But as you can see, it falls rather short in terms of the Why Asthma Still Kills recommendations, and so this template that we created is just the first step in that line of pushing forward to improving the quality of care. So from having a look at this, our in-house pharmacist recommended a couple of things that we should look at, and first one being that before an annual review that we've got clear documentation of how many reliever inhalers and also inhaled corticosteroid inhalers are used in the previous 12 months, that 3 RCGP questions are asked, that inhaler technique is checked using a checked-R device, making sure that every patient has a personalised asthma action plan and that only one inhaler is given at a time, and also that steroid inhalers are only issued up to a maximum of 10 in a 12-month period, because actually that should be long enough to cover that time. So as you can see here, a screenshot of the asthma care review that we had created. Now, going from top to bottom, you can see for a start that first we hit the QIP points with the 3 RCGP codes, as well as the asthma review, and also we look at smoking. We start touching on that medication review that we were talking about earlier, so that we know that we're looking at the number of reliever inhalers and also the number of steroid inhalers that are being used. We've got a prompt here to use the check-dial device to show that we have used it and they are on the appropriate type of inhaler and that they've got the required strength to actually use the inhaler. And also we've got serial peak flow rates there. At the bottom as well, we've managed to create our own specific Word document which effectively just utilises the BTS guide for an asthma management plan. And as you can see from this, it's very similar to the BTS one, but we've just added our own flavour to it with our own practice. So we've got our own practice codes and our own practice numbers on there, as well as detailing of our own local out-of-hours service that's present. So in this video, we've looked at the recommendations of why asthma still kills, and also touched upon the QIP templates that are already freely available and amalgamated the two to try and push forward into a template that improves care of our asthmatic patients. If you're interested in getting a quote for this template for your own practice, please feel free to email me admin@gptemplates.co.uk. Please don't forget to like this video and comment on this video if there are any more videos like this that you would like to see. Please don't forget to follow me on other social media platforms with the handle @gp_templates. That's on Twitter, Facebook and Instagram as well. Many thanks for your time and happy template building.